visiting professor, guest of honor. Let me do a little history. I heard the name already. Someone said, who was this gentleman?
Marshall Parks.
Marshall M. Parks. Marshall Miller Parks. He was born in Michigan, in Old Mission, Michigan. He went to college in Illinois College, went to medical school at St. Louis University, graduated in 1943, and he was inducted to the AOA, because he was, did so well in medical school, and then in World War II he served in the Pacific Theater in the Navy. Then coming back, he went into ophthalmology and studied under Kostenbader, and was at the Children's Hospital in Washington, D.C. He was basically, he's the father of pediatric ophthalmology. That's how he's called, and he's, trained, and he also did they started the first fellowship for pediatric ophthalmology in Washington, D.C., and he's trained many pediatric ophthalmologist, published many papers, was also honored by the American Academy of Ophthalmology, and many named lectures, one of the giants in the field of ophthalmology, especially pediatric ophthalmology. All right. Let's see. Let's go to the laptop.
There we go.
Okay. You want to say a few words?
It's very simple to introduce her. She only went to one school.
Yeah.
I guess did you go there for preschool too?
Not quite.
They do have a very nice preschool.
They do. My children have been through it.
My children have gone through it as well. It's a pleasure to welcome Susan Culligan here today. Susan did most of her higher education at Washington University in St. Louis. She was there as an undergraduate at the college, then stayed on for medical school there, where she was in the MST program. So she obtained both an MD and a PhD. She then wandered far away to Barnes Hospital, where she did her medicine internship. Then went through the residency program about two doors down at McMillan Hospital at the Department of Ophthalmology at Washington University, and did her fellowship in St. Louis Children's Hospital in pediatric ophthalmology, and she's now on the faculty there in pediatric ophthalmology. So it's very easy to remember where Susan has received her education. She has always had an abiding interest in neuroscience and ophthalmology, and you'll hear later on today about her work with particular geniculate projections, etc. But she's going to talk to us this morning about nystagmus in children. Susan, welcome.
Thank you. Good morning. Thank you very much for inviting me to come speak. It's a pleasure to be here, and I hope we're all going to learn a little bit about nystagmus this morning. We'll start with the obligatory disclaimers. I have not figured out how to make any money on this topic, but if anyone has any ideas, I'm very interested to hear them. Number two, I hate nystagmus. So I don't like to give lectures that are not very, thoughtful or helpful in terms of teaching, so I made the mistake of asking what it was that the residents would like to hear about, and Dr. Rifkin very kindly gave me a topic that I dislike, but it was a good idea because it forced me to review the topic. I suspect that in some way, shape, or form all of you residents hate nystagmus too, because number one, I've been a resident and I know better. Number two, Dr. Rifkin asked me to talk about it. Okay, another disclaimer. I am a lumper, not a splitter. So you're not going to get long lists of differential diagnoses in this talk. That's not how my brain works. It's that PhD thing. But there are ample opportunities to split nystagmus by lots of different ways, and we'll kind of go through that a little bit. And I have some tips a little bit later about how to go through some of those things. All right, why I hate nystagmus. There are a number of reasons. It can be clinically complicated. There are a lot of elements in nystagmus, and sometimes it's difficult to sort those out clinically. It can be anatomically complicated. It's not always clear what is causing nystagmus, what neural mechanisms are disrupted that cause a child or an adult, for that matter, to develop a nystagmus complex. For the same reason, the pathophysiology is not always clear. You know, if you can find the brain tumor, you can say it's caused by the brain tumor, but it's a little more complex to ask why the brain tumor in that position is causing nystagmus as opposed to any other thing it could cause. And in pediatrics in particular, it can be a harbinger of badness, which is never a good thing. So not everyone hates nystagmus. And Agnes Wong is a neuro-ophthalmologist at Sick Kids in Toronto, and she's written this book on eye movement disorders that I would highly recommend to any and all of you, not just to understand nystagmus, but eye movements in general. It's a very well-written text. It's got very clear figures that make things that are complicated make much more sense. Many of the figures that I have in this talk came from this book, and it's a great one. If you don't have it on your library shelf, you should at least make sure you have it in your library because it's a great resource. Okay. What is nystagmus? Nystagmus is involuntary oscillations, and they force the eye to make a slow movement off of target. So the fovea is trying to fixate on the target, and the nystagmus is pulling the eye slowly away. And then there's a saccadic refixation movement to put the eye back on the target. There are phenotypic ways to classify nystagmus. So we're talking now, we're going to try to split a little bit. Phenotypes, it could be pendular or it could be jerk. These are the, is there a pointer? I'll just wander. So the pendular nystagmus has the slow phase in both directions. The jerk nystagmus has a slow phase in one direction with the jerk refixation in the opposite. They can be horizontal or rotary.
Can I give you this pointer, doctorate?
That would be fantastic. Thank you very much. Let's see. Yeah, great. Okay, thank you. The movements can be horizontal, vertical, or rotary. You can have conjugate or inconjugate, disconjugate nystagmus, and this isn't showing up very well, but this is a conjugate nystagmus. This is the right eye position, this is the left eye position. You can see when one moves to the left, the other moves to the left. When it moves to the right, the other moves to the right, and they're moving in phase with each other. Or you can have disconjugate nystagmus, where that's not always the case. In this case, this eye is moving this way, this eye is moving this way. The eyes are not moving together. You can discuss the amplitude of the nystagmus. You can discuss the frequency of the nystagmus. However, these kinds of things are not often clinically useful because they aren't necessarily going to put you in a particular direction about what's causing the nystagmus, and many of them you can't even really discuss well without doing extra electrodiagnostic testing, such as we saw in the square wave traces earlier. So another classification system would be based on the pathophysiology. What's causing the nystagmus? What system's disrupted? There are three basic motility systems that are responsible for disruption in nystagmus complex. The first is the vestibular ocular reflex. The second is the gaze holding system. And the third is the smooth pursuit, and we lump that together with optokinetic system. They're both sort of elements of the same system, one being fine and one being gross. Okay, the VOR. The residents should all be familiar with this. If you're not already, get that way, because when you take your OCAPs, it'll be on there. This is the idea that when you are moving your head in space and you want to fixate the target, your eyes are going to move in the opposite direction, and they're going to do this based on the speed and the velocity of the head turn. So it's a counter-rolling reflex, so that the object, if I'm looking at the painting on the wall and I'm turning my head this way, the eyes are going to still continue to point at the painting. So this is a brief outline of how this thing works. This is just the horizontal system. There are semicircular canals that will translate motility in the horizontal, the vertical, and the roll plane. But this is just the horizontal system. I'm not going to go through each one in graphic detail. But the concept is the same. These are the horizontal canals. And if you're rotating the head to the right, the eyes rotating to the right, there's an increase in activity in the right canal, which then will activate the neurons in the sixth nucleus on the opposite side. Ultimately, you'll have activation of the lateral rectus in the left eye and the medial rectus in the right to move the eyes in the opposite direction. At the same time, there's inhibitory inputs to the nuclei that control the ipsilateral lateral rectus and the contralateral medial rectus to account for that movement of the eyes opposite the direction of the head turn. So these are not common nystagmus syndromes in childhood. This is the one you're going to see in adults with stroke. And that sort of makes sense, right? There's a lot of brainstem nuclei there. There's a lot going on that can be disrupted, which is not pretty typical of pathology you would see in children. However, lots of things can cause problems and induce nystagmus with a VOR component, particularly drugs, strokes, tumors. The drugs you can see drug side effects in children, but they're not typically on drugs that cause these effects. The one time you may see this mechanism at play in children is in Arnold-Chiari malformation. Okay, so let's switch gears and talk a little bit about the gaze holding system. So the gaze holding system is the idea that you're going to want to keep your fovea fixated on the target of interest. And this is going to be through both reflexive and volitional saccades. All right, now it gets interesting. So this is the part that I had to study, and I'm still not completely convinced that I got it. But the gaze holding system is dependent on what's referred to as the neural integrator. And the neural integrator is a neural circuit that will translate velocity information, which can be encoded neurally by just increasing your firing rate, right, into a position in the orbit. So I've got my gas gauge on the slide to remind me to go through my analogy. So if you are trying to get from point A to point B on the highway, and you're in a car, you've got a gas pedal, you've got to go on the acceleration ramp to get on the highway and then drive on the highway to get to where you're going. You're going to push hard on that pedal when you're at rest. You're at zero, you're going to have to push hard on the pedal. You're going to get up to 60 miles an hour. You want the car to move, you want your eye to move, so you're going to hit a pulse. You're going to send a long trail of action potentials to the muscle. Once you get on the highway, what happens if you now take your foot off the accelerator? Are you going to get to where you're going? You're not. The car's going to stop, and if you're on a hill, it's going to roll right back to where it started. And there's an elastic and recoil set point in the orbit where if you don't have your firing rate above the tonic rate, the eye's just going to reposition into its resting state. So there's a pulse and a step to get the eye where it's going. There's a pulse, a long train of action potentials. If you don't have a sustained pulse, a sustained step after that, the eye's going to go right back where it was in the orbit. But you have a big pulse, you move the eye to where you want it to be, and then you reduce it. It's the same idea as when you're accelerating on the on-ramp, you've got your foot to the floor, you get onto the highway, you back off the gas a little bit so that you can sustain where you're heading. Your velocity is constant, but you're above your baseline. And this is what the neural integrator translates into a position cue. So your brain can't encode position in space. It can encode velocity. It can encode temporal things, but it can't encode spatial. So it has to translate this. And the way that it does it is with visual feedback. So there's some top-down connections from the cortex that sense, okay, we've accelerated this much. The eye is pointing at the object of interest. Now we're going to back off a little bit. That's our step. The eye is exactly where I want it in space. We're all good. We saccade to the right spot. But in cases where the feedback loop or the integrator itself is not tuned properly, you're going to have an overshoot of your target, or you're going to have an undershoot of your target, or you're just not going to be able to maintain the target, and there'll be a nystagmus. Does that make sense to everyone? Okay. And these are where the neural integrators are thought to reside. So for horizontal movements, they're in the medial vestibular nucleus and the hypoglossal and the interstitial nucleus of Cajal for the vertical and torsional movements.
So, Susan, you mentioned that you can't correlate where the anatomical defect is necessarily with the type of nystagmus. But I would suspect that in the gaze holding system, it would be really unusual to have pendulum nystagmus, or is that not true? Whereas it might be more likely to have the concomitant type of...
You can have both.
Really?
Yeah, you can have both. The more common is jerk nystagmus, but I guess it depends on where the defect is. So one of the pendular nystagmus syndromes is sensory nystagmus, and you can get pendular nystagmus with a sensory nystagmus. And there, it's thought to be a gaze-holding system defect, but it's the feedback. There's something disrupted because the eye can't see. The top-down feedback onto the gaze-holding system is abnormal, and so then you end up with a pendular nystagmus. So if you can still see and you're overshooting and readjusting, it's going to be a different characteristic than if you can't see at all.
I gotta tell you, I love that analogy about the gas pedal. Has anybody here ever ridden with Rich Eifman? Because he drives with Mustangs.
He has a leaky integrator.
I mean, no, seriously, I'm in the passenger seat, you're going back and forth like this the whole way down the highway.
Wait a minute. On Monday, did we not have the same phenomenon? We traveled with Schulman up to the Carl Clinic.
Oh, God.
It was the exact same thing. I mean, you know, we had to change cars. It was so bad.
All right, so let's talk a little bit about nystagmus that you can get. So this is a gaze-holding system nystagmus. This is what we call the leaky integrator. So the normal saccade, you have your pulse and your step, and that produces an eye movement. Here's your pulse, and then your step sustains it. So this allows the eye to be maintained positionally in space because you've got that step holding it once it gets to its achieved point. Now, with what they call the leaky integrator, you don't have a nice square step here. It's sort of a slip instead of a step. And when you have a slip in your firing rate, because remember, we can't encode position sense with neural systems. We have to encode velocity or firing rate. When you lose your firing rate here because you're slipping, you're going to lose your position. You're going to slip of your position as well. So you've got your pulse that gets the eye to where it wants to be, your end gaze, and then your integrator slips and it starts to slide back, and then the top-down mechanism's in play. It says, wait a minute, that's not what I'm supposed to be looking at. Slides back. Then it slips again, and then it slides back. So that's your end gaze nystagmus. That's a gaze-holding system nystagmus. Other examples are an INO. You can imagine how that works, right? Because that's a disruption in the circuit itself. All right, the third system, smooth pursuit and optokinetic systems. So these are basically the same thing, gross and fine. So smooth pursuit, you want to have the eyes follow a slowly moving object across the visual field so that the object of interest maintains fixation on the fovea. OKN is the same concept, but it doesn't require foveation. It's a much grosser mechanism. And in other mammals that don't have a fovea, they can still have optokinetic nystagmus because they have that refixation movement. For example, rabbits don't have a fovea. You can get them to be induced in OKN, an optokinetic nystagmus with an OKN drum, but they can't do smooth pursuit because they don't have a fovea, so there's nothing to fixate on the target. But this is sort of gross and fine examples of the same general mechanism where you're trying to fixate a target. Okay. Fixates the target on the fovea. Its other job is to cancel the VOR doing combined head movement and eye tracking. Because you can imagine if you're trying to track a slowly moving object, you're looking, I don't know, maybe at a satellite that's going across the sky, you're not just going to follow it with your eye. You're going to follow it with your eye for a while, and then you're going to move your head and follow it again, and you're going to keep making little movements as it goes across, right? The problem is, what does the VOR do? If you move your head, where do your eyes go? The opposite direction, right? So if you're trying to track an object with your eyes and your head in one direction, you don't want VOR moving your eyes back in the other direction. So the smooth pursuit system actually cancels out that VOR while you're trying to do smooth pursuit. The other thing that happens is the OKN can kick in. Remember, OKN is gross, so you can even take a newspaper and induce optokinetic nystagmus, right? This is a pretty gross system. If you're following a small object across a stationary background, the elements in the background could actually induce OKN. You don't want that to happen. You want, because your eyes are tracking across that background. If you got, you know, let's say fence posts, right? You know, you could actually induce an OKN. But you're following the rabbit that's running along them, then you're going to want to cancel out that OKN response while you're doing smooth pursuit. This pathway is not completely understood. I really tried to be able to draw out the pathway for this one so that you'd understand it, and it's just not well known. So people are making careers on this as we speak. We know it involves higher order areas. If you lesion those areas, you can get some complicated syndromes, some which involve nystagmus and some don't, but they're complicated neural circuits. Okay, an example of a smooth pursuit nystagmus is fusion maldevelopment nystagmus, or what we refer to as latent nystagmus. And I'll use these two terms interchangeably. I like latent nystagmus because that's what I grew up on, but Larry Tyson tells me I have to learn fusion maldevelopment nystagmus, which is too long. This is what you get when you've had esotropia as a young infant, and when you occlude one eye, you get nystagmus. Okay? So, for the benefit of the splitters, we've got all the big long list. And my brain just doesn't think this way, so I couldn't get my head around this. But as you can see, if you want to split, there's plenty of ways of doing it. This is from Agnes's book, and I would strongly recommend it if you really want to go into this a little more detail, because it's really a pretty good way of breaking down the complex topic. This is chapter 7, by the way. Okay, so we have a couple different ways of doing this. We can do phenotypic characteristics, we can do pathophysiology, but again, even with pathophysiology, it's sort of marginally useful. If we know what the system is, it doesn't necessarily better help us diagnose the patient, helps us understand why it's happening, but it's not going to get us to where we need to be. So,
Susan, before you go on for a second, can you clarify something about OKN? Because I'm not quite sure. Do they understand whether or not the OKN phenomena is occurring primarily from a rod-dominant input or a cone-dominant input, or is it a mixed input?
It's mixed input. So you can induce OKN even in cones. So even a gross stimulus will still induce an OKN, but you can't do the opposite. You can't do smooth pursuit with rods. And it's probably just a spatial acuity thing, that there's something about the acuity in the target. And the one will trump the other. Smooth pursuit will always trump OKN. So if you have both, smooth pursuit will trump OKN. If you don't, you just get OKN. So it's going to be very dependent on whether or not you have the spatial acuity to be able to do smooth pursuit.
So rodents, for example, who obviously don't have a fovea, they have a rod-dominant retina, but do have cone photoreceptors scattered throughout the entire retina.
Right.
If they had loss of their rod photoreceptors, that would presumably destroy their ability to resolve images on the OKN.
I'm sorry, if they lost their rods? Yes, because
retinitis pigmentosa, for example.
Right. I would suspect that yes, it would, because there's just not enough information there to integrate to be able to do it. That's a guess. I don't know the answer to that question. Okay, so another way that we can classify nystagmus, congenital or acquired. This is a more clinically useful way of splitting things, right? Because now you can start thinking about the pathology that is going on that's causing this problem. And particularly because, you know, acquired nystagmus in an adult is going to require a bit of a workup, because you want to know what's going on. Is there a stroke? Is there a tumor? Is this a neurodegenerative disorder? I'm not going to talk about those things because I'm a pediatric ophthalmologist. Okay, this is my favorite classification. So now we're getting to the nitty-gritty of you're in the clinic with a bunch of kids and mom comes in and you got a kid that's got nystagmus, and chief complaint is his eyes are jiggling, all right? The classification is blind, not blind, common, not common, okay? That's how I like to split it out. So blind, not blind, sensory nystagmus if they're not seeing well, and common, not common. Common disorders in kids are the fusion maldevelopment nystagmus, latent nystagmus, which we see all the time, and congenital motor nystagmus. Okay, so this is the Greg Leader approach to congenital nystagmus. What is the most important question you can ask the mom in the history when she brings in the 6-month-old and says his eyes are jiggling? And I'm not going to ask John because he better know the answer. If he doesn't, he has to go back and do his fellowship again. When did it start? Okay, that's one. What else would you want to ask?
So one eye or both eyes?
One eye or both eyes. Okay. What else?
Can I interrupt just?
Yeah, please.
I want everybody to know this, that when I was doing the oral boards, I was doing pediatrics, and there's a softball question about nystagmus, and the candidate was struggling, and finally he said, gee, I think maybe the child has nystagmus. And I said, are there different kinds of nystagmus? And the candidate said, I don't know much about nystagmus. And I said to myself, if you come to your oral boards and you don't know anything about nystagmus, you need to go home and study again.
Yeah.
So I hope everybody's listening to this. This is wonderful. Please, please, I'm really enjoying this.
Thank you.
No, really. I mean,
At least they'll be able to know there's more than one kind of
I
nystagmus.
don't care what the kid said, pendular jerk, acquired, you know, he could have said anything. I want to go on to the next question. So.
All right, another question? Let's go back to my favorite way of classifying nystagmus.
Yeah.
Do you think the kid
Blind or
can
not?
see? Yeah, exactly. So mom's going to tell you. If you ask mom, do you think he can see? Oh yeah, he reaches for toys, he smiles at me. Then you're going, okay, cool, this is going to be congenital motor nystagmus, we're all good. Or mom will go, you know, I don't know. I can't really tell. Sometimes I think he is, and then other times I'm not so sure. And then your stomach kind of goes because you know you're going to be in for a big workup and it might be ugly. All right, so the answer, do you think your baby can see you? So what are the causes of congenital sensory nystagmus? Well, they're myriad, right? There's lots and lots of different causes for kids to be blind. But again, my favorite classification, common, uncommon. So common things, optic nerve anomalies. Optic nerve hypoplasia is extremely common in kids. And you can get a sensory nystagmus with either unilateral or bilateral optic nerve hypoplasia. We can argue a little bit about whether the unilateral hypoplasia is really a fusion maldevelopment nystagmus or a true sensory nystagmus. That's one of those things you'd have to have a Agnes Wong in the room to moderate. I'm not sure I could answer the question. But you do get nystagmus with even unilateral optic nerve hypoplasia. Optic nerve dysplasia, optic atrophy. We see quite a bit of this in our practice because we've got a lot of preemie kids that had hydrocephalus and got shunts, and they'll have some optic nerve damage as a consequence of that. So these are all very common things that we see in our clinic. Colobomas, they're not really common, but we see them quite a bit, and those are going to have visual defects associated with them and therefore development of a sensory nystagmus. And ocular albinism. So uncommon ones, which are the ones that make my stomach sink because I'm never quite sure what to do. Bilateral cataract I put up here because it certainly is a cause of nystagmus. It's not common at all because pediatricians actually are pretty savvy about picking these things up. Most kids that are going to have bilateral cataract, it's an inherited thing from the family, and the parents are clued in, and we'll see these kids 2, 3 to 4 days old. The rod cone dystrophies, these are the ones that we have to do additional visual diagnostic testing. You're not going to make a diagnosis of congenital stationary night blindness in the office without getting an ERG. Having said that, there are things associated with this. Does anyone know what the one thing you could check for in the office might be? You could do retinoscopy. What else can you do for CSNB? There's a finding in CSNB that you can look for. Pupillary. What happens with the pupils?
When you shine the light, it dilates.
It dilates, exactly. Paradoxical pupils. So that can clue you in. All right, and Leber's is another one. All right, so now the fun begins. So let's see what some of these look like. So here is a sensory nystagmus in ocular albinism. And is it just slow or is it not going to run?
It probably, if it hasn't come up, it probably
Isn't going to run?
Do you have it separately?
I do.
If you just go out of the program and just click on it, it may very well. It tends to be temporary.
So,
What did I call it? I'm not finding it. I might not have that one. All right, well, we'll have to run the long one that I didn't edit, which is unfortunate, but that's okay. It's not too long. So this is a...
Who's the patient?
The patient's actually the child, but the mom brought her in to make sure she didn't have the same thing that she had. So what she got? Well, I guess I already said it, but
Albinism,
yeah, but it's pretty obvious. There's nothing subtle about this. So, and this is why I don't like that first. So those are the transillumination defects. You can see she's just like, you can see the light right through the iris. There's no block in that at all. So very bright. And that's the normal infant. So mom's got it, infant does not. So let's go back a little bit, see if I can get it to do that. I don't know how to do it on this thing. Oh, I'll play it again.
There you go. Yeah.
I'll just play it again. When we look at her eyes jiggle, so we talked before about frequency, amplitude, jerk, or pendular. Can you tell whether this is a pendular nystagmus or whether it's a high amplitude jerk? I can. I mean, you can tell when you put her on in the EOG. Looks pendular to me, but my residents were arguing that it was jerk but a very fast frequency. Yeah. So without that trace, you can't answer that question, which is why I find those characteristics very limiting in the clinical setting. Okay, I don't have to look at the baby anymore. All right, so let's go back to here. Okay, so the recommended treatment for sensory nystagmus is going to be to treat the underlying condition. So, you know, for example, if you got the baby with the bilateral cataracts, obviously you want to take the cataracts out. Refer for services when possible. So we have Delta Gamma in St. Louis. I don't know what similar thing you have here, but I suspect there's some pediatric eye foundation or system in place to refer young children with visual disabilities. And this is going to be the most important thing you can do for these kids. Let me reiterate. This is going to be the most important thing you can do for these kids, because they will get them plugged in through the system so that they have support in schools, so that there's communication back and forth between the pediatrician and the systems that are going to have then this child going through them all the way up on through. And that's going to be the most important thing, because they're not going to be able to treat the defect in vision. This is something that's done. They're wired wrong for whatever reason, so at least you can provide the support that they need to get through life.
Does everybody know what that is here? Visually impaired preschool services, VIPS.
Okay.
We do have that here.
Yeah, I kind of figured, but I didn't know what it was. I should have emailed and asked. I would have put VIPS on there instead of Delta Gamma, but it's the same concept. Okay, this is the Larry Tyson approach to congenital nystagmus. Common things are common. What are you going to see every single day in my clinic when you walk into Children's Hospital? You will see nystagmus at least once every clinic day, and this is most likely to be the one you're going to see. Why? Because we got tons of infantile esotropia in the clinic, and a lot of these kids don't get repaired early enough to avoid the confusion maldevelopment nystagmus. Does anyone know approximately how old you have to repair the strabismus for them not to develop this? Any guesses?
2 months.
A little later.
6 months.
6 months. You have to repair before 6 months. How many of these kids get repaired before 6 months? Well, most of them don't even present before 6 months. So very commonly, they've already got the fusion maldevelopment nystagmus before you've even met them. Okay, congenital motor nystagmus is also another one that's pretty common. So fusion maldevelopment nystagmus, you are going to look for the associated findings. Obviously, the most common one is the infantile esotropia. Less commonly, you can have the other forms of strabismus. Any lesion that disrupts binocular development is going to cause this. So we argued before about with unilateral optic nerve hypoplasia, is it a sensory nystagmus or is it a fusion maldevelopment nystagmus? This is why, because it comes up here. Anything that disrupts this binocular development is going to cause the latent nystagmus. You're going to find a dissociated vertical deviation and pursuit asymmetry, because all of these things are part of the same neural pathway that causes the fusion maldevelopment nystagmus. So what are the characteristics? Actually, I wanted to put this after the movie. I'll ask you guys to look for some of these things. Yeah, this one looks like it might play. Maybe, yeah. So what happens when he covers the eye? So what direction is the nystagmus in this child?
Horizontal.
So, come again? Everybody's talking.
Horizontal.
Horizontal, okay. And which direction's the slow and which direction's the fast?
Oh, you can't tell.
You can tell there.
The fastest to the left.
The fastest to the left. Look at.
Fastest to the vertigo. Fastest over the
It's kind of a trick question. We'll look again.
What difference does it make?
It does make a difference. We'll talk about it in a minute.
Is it important?
It is important. Yeah. So which direction's the fast phase here? To the left. Which direction's the fast phase here? To the right, exactly. All right? So in fusion maldevelopment nystagmus, the eye drifts to the nose and then refixates to the temporal side. And it doesn't matter which eye you cover, it's going to drift to the nose and refixate to the temporal side. So you're going to get a different direction depending on which eye is covered. All other nystagmus is the same. If it's slow phase to the left, no matter which eye you cover, it's slow phase to the left. Fusion maldevelopment nystagmus is the exception to that. So it does actually help you to make the diagnosis in this particular case. And now I can't figure out how to get out of this thing.
Just hit escape.
There we go. Okay. So this is, I'm going to go back actually and talk about this. Okay. So it's evoked or enhanced by monocular inclusion. So in some cases, you don't notice any nystagmus until you cover the eye, and then all of a sudden, and actually that kid was a little bit like that. There may have been a little nystagmus, but you didn't really see it until you put the hand up, and then all of a sudden the eyes are going. So as long as they're binocular, they do pretty well. So this is another little tidbit. When you're trying to check vision in a kid that's a congenital esotrope, he's since been repaired, but he's got fusion maldevelopment nystagmus, generally does pretty well sitting in the chair, but now you go to test his vision, and he's 20/60, what can you do? What's a little trick you can do to try to see, is he really 20/60? Because when he's binocular, he's 20/20. You can fog his other eye, exactly. Instead of occluding, you just blur. So you can put a +15 lens up in front of the other eye, and that keeps input coming to that eye. It's degraded, but it's enough that they don't get as big a drift with a nystagmus. All right, it's usually a conjugate horizontal nystagmus with quick phases beating toward the fixating eye. And the direction of the nystagmus reverses depending on which eye is fixating. So that's what differentiates it from the other forms of nystagmus.
Can this be ever rotary?
It can. Yes, it can. I don't know in rotary nystagmus which way the fast phase is. It can be rotary.
Especially the latent manifest nystagmus.
Yes, yes, yeah. If you've got like a kid that's has had degrading vision in one eye, and then it's completely like an ROP kid that's been sort of hanging on to the vision in one eye for a while, hanging on, and then they get the detachment. Now it's gone. Now they're going to get manifest latent nystagmus in their opposite eye, and they'll often have a rotary component. But I don't recall which way the fast phase is. If there's and there may not be a rule. Was it John? I was telling last night. There's a whole paper that Larry Tyson wrote on the mechanism of fusion maldevelopment nystagmus, and I almost was going to try to put it in here, and I decided it was too complicated, and it's Larry's talk, not mine, so I left it out. But the idea is that the reason that they think it develops is just like the retina develops from the nasal retina develops before the temporal retina, the pathways in the brain are also more mature for nasal word motion before temporal word motion, which makes sense. Why would you develop your temporal first if your retina is still developing? So those systems are mature at the time that all the other stuff's getting, the nasal word one is mature when everything else is getting disrupted. So the temporal word processing never quite develops because that's when things get disrupted. And so the nasal word refixation is because you've got this temporal drift, because just like you have your leaky integrator that allows things to drift in your gaze fixating, this one, it's kind of drifting to the temporal side because it hasn't developed the ability yet to kind of hone it in and fix it, and then you refixate to put the image back on the retina. But with rotary, I don't know that there's any same developmental paradigm that would cause it to necessarily be in one direction or another. Okay, so let's look at the DVD. So we're going to look at the occluded eye when the occlusion goes away. See that? And this is pursuit asymmetry. So you can see when she fixates with the right eye, she's nice and smooth. Here she does nasal word fine, but jerk, jerk, jerk. Nasal word fine, jerk, jerk, jerk. Nasal word fine. And that's again, that same development. You can do nasal word tracking pretty easily because that's mature when this comes online, but the temporal word tracking gets disrupted. There's the DVD. Normal tracking both directions, nasal word and temporal. Here, nasal word's fine. Jerk, jerk, jerk. And it becomes more prominent after midline. Okay. So now we'll move to, uh-oh, something's missing there. Okay. Now we're at congenital nystagmus. I hope I have another slide later. Oh yeah, there it is. Okay. So this is just congenital motor nystagmus. Now I want you to look here and tell me what you notice about this. All right, so you got nystagmus there? What's happening? They're going away from it, exactly. So watch this. You're just going to come up again. So you have a lot of nystagmus there? No. Now you start to see it. Now you get them all the way out to the opposite side, and what have you got? Big jerky movements, right? And you can tell he can't even really fixate the target. The eye's just wandering away. Okay? So what are the characteristics of congenital motor nystagmus?
Got a head turn.
Head turn, right. So that's very common. So it's usually horizontal. Doesn't have to be, but this is the predominant characteristic. They can have nystagmus blockage syndrome. So this is one of those where they'll converge. They look like they're esotropic, and you always wonder, okay, are they esotropic and nystagmus? Is this going to be congenital latent nystagmus we just talked about? Is it fusion maldevelopment nystagmus? Or do they have congenital motor nystagmus, and they're dampening their nystagmus by converging? So you have to be able to tease those two things out, right? Because if it's fusion maldevelopment nystagmus, you need to go do ET surgery. If they're dampening their other nystagmus, it might make things worse if you try to fix it. Okay. Visual acuity is related to the foveation time. So that's why they develop the null point head turn, because they want to decrease the amount of time that the eye is jiggling all over the place. You want to foveate and be able to see clearly. And a lot of these kids can have very good visual acuity if you let them sit in their head posture. That kid that had his head cranked all the way to the side, he's probably got pretty decent vision. You can see that his eyes jiggled very little when he was way over to the side. But if you then make them sit in primary, their eyes jiggle all over the place, and the visual acuity rapidly degrades. And then the null zone. These kids very frequently will have a head turn to try to put their head in that null zone. So the management. So on a cycloplegic refraction in these kids, they can have high levels of astigmatism. And it was funny, when I was doing this research, I was like, does that mean it's something different than a fusion maldevelopment nystagmus? I mean, this sounds, or a sensory nystagmus rather, this sounds like it could be sort of like an isoemetropic amblyopia. There may be an element of the sensory nystagmus in here. Although the characteristics are sometimes a little different. You want to give them prism if they're actually dampening the nystagmus by converging. You don't want to do surgery on these kids necessarily. And you can do a Kestenbaum procedure for the kids that have a null point. What's a Kestenbaum procedure? Anybody?
Yeah, you do an R&R.
Yeah. So if this is the kid that we were looking at with the big face turn and the eyes all the way in the far orbit looking to the right, for a left face turn and a right gaze preference, you're going to assume that you're going to treat the right eye as if it has a big XT and the left eye as if it's got a big ET, and you're just going to move this eye over this way and this eye over this way. Okay? So 4 muscles. Okay. Uncommon pediatric nystagmus, spasmus nutans. So this is one you have to talk about because, you know, pediatric nystagmus, spasmus nutans, they go together on the OCAPs, right? It's a triad. It's the nystagmus, there's a head bobbing, and there's an abnormal head posture, so torticollis. The issue here is that it may sometimes be associated with gliomas, particularly chiasmal gliomas. So, we'll look at the picture. And this is an older child. No, maybe not. It doesn't look like it's working.
I think Dennis can play his video. He's got an interesting case to show you.
Okay.
Well, you had it on there.
Yeah, it's in there. I just have to.
It's on your menu.
I have to get it to. I don't know. Some of them worked, some of them didn't. It's just kind of a randomness is odd, but anyhow. So what's she doing?
Saying no.
That's the head bobbing, right? Hers is this way. Head bobbing. And now when she gets the nystagmus, this, is that conjugate or disconjugate?
Disconjugate.
Disconjugate. They're like all over the place. Look at that.
16.
So disconjugate nystagmus. Head bobbing. And I don't know if they've got a good image of the alternate head posture in this video. No, apparently not. But they'll often have a head tilt. Okay, now we gotta find my presentation again. Okay. To scan or not to scan, that is the question, right? Because these can be associated with tumors. The problem is they're usually not associated with tumors. So Kyle Arnaldi, who's now at Buffalo, and Larry Tyson back in 1996 went through 67 cases at Children's Hospital that had at least 3.5 years of follow-up. Not quite 3.5, 3.25. And about half of those patients had been scanned at the time of diagnosis and half of them had not been scanned. And they followed the rest of them that weren't scanned to see if there was any evidence of progressive deterioration that would warrant having a scan. And despite scanning over half of them and following the other half, not a single one had a tumor associated with the spasmus nutans. So this is going to become an issue. We're already seeing it with third nerve palsies in neuro-ophthalmology. It is the day of cost-effective medicine. It's upon us. It hasn't been forced down our throats yet, but it's coming like a freight train. And so we need to think about these things. And I think the other thing they found that I didn't put up here is 67% of these kids had developmental delay. And I can tell you every single kid I've seen in my clinic that has spasmus nutans has developmental delay. They're either premature or they're Down syndrome, and it's very common in Down syndrome. So if you've got a kid with a developmental delay, you've sort of got your explanation for your spasmus nutans. Unless there's other neurologic conditions that are concerning to you that you would want to get a scan, you can probably just observe. If you've got a kid without developmental delay, there's any other neurologic signs that you're concerned about, it's probably worth getting a scan. But it's still a rare complication.
So in these 67 cases, how many had developmental delay?
67%
In this group?
in this group,
So
over 40 of them.
So now you're talking about 30 cases that you might have imaged.
Right,
Because-
right,
because
right.
of-
And now I don't know that they knew that, but when they did the study, that's what came out of the study, is that if it's that is common with developmental delay. I mean, it was shocking. 2/3 of kids that present with spasmus nutans have developmental delay. I don't think that anybody would have predicted that beforehand. Yeah. Okay, so what is the nystagmus? It's pendular. It's intermittent. It's not always there. They didn't really hone in on the girl's eyes when we first started the video clip, but she didn't have nystagmus when they started, and then it started kicking in a little bit later. It's small amplitude but high frequency. It's often disconjugate. It can change. The characteristic of it can change as you're watching it, which certainly it did in that video clip. It's predominantly horizontal, but there can be other components. The Down syndrome kid I have in my clinic that I'm following now actually has a torsional component. Her nystagmus is sort of a rotating nystagmus. It's typically present in the first year of life. There are no other associated neurologic abnormalities. That's the key right there. If you find other focal neurologic deficits, you're going to have to scan these kids. And typically, there's spontaneous remission in about 2 years after the diagnosis is made, but not always.
What do you mean by disjunctive? Is it the vertical and the horizontal?
Yeah, that's where they're going in opposite directions from each other. So disconjugate, one sort of moves, you know, more than the other, but they're both moving in the same direction. Disjunctive is they're actually, and you saw it with her, she kind of went, it almost looked like a big XT or something. Okay? All right, so we're at the end. Common nystagmus syndromes are fusion maldevelopment nystagmus or latent nystagmus, congenital motor nystagmus, and sensory nystagmus in the pediatric population. These are the ones you're going to see frequently. Make sure that if you have a kid with a sensory nystagmus that you're getting them the appropriate support services through your VIP, right? Is that right? VIPs. And for kids that have a congenital motor nystagmus with an alternate head posture, you can do surgical correction with a Kestenbaum to try to put the null zone in primary gaze. Any nystagmus that has a sensory component, but you can't identify the cause. Your optic nerves look good, your retina looks good, everything sort of anatomically looks intact, but it's clear that the kid's not seeing. They're going to need additional testing, and an ERG is probably warranted. And for spasmus nutans, you can probably defer the neuroimaging if there's no other neurologic signs, particularly if the kid has developmental delay, to avoid the anesthesia and the cost. The anesthesia is probably another point to touch on here. It's very hotly contested and debated, but more and more evidence is coming out suggesting that long anesthesias and multiple anesthesias in young children is associated with later developmental delays and learning disabilities. So I think that's going to take a number of years to sort out completely, but there's accumulation of circumstantial evidence to suggest this. So at least in my practice now, I really think every single time I recommend an anesthesia for a child, do I really need to do this or not? And if I do, great, we got to do it. We don't want to miss a brain tumor. We don't want the kid to die so that he doesn't get a reading disability when he's in 6th grade. But at the same time, if it's a kid with Down syndrome and I don't really think there's going to be a tumor and I'm just trying to, placate mom, I might think twice about it. And usually just having the conversation about, well, this is what the anesthesia could do. It's not benign, is sufficient to make mom realize I've thought about it and I'm going to watch. I'm not going to just send your kid home and say they're fine. But at the same time, we're not going to subject them to any additional harm because we don't really need the imaging. I think that's it. That is all. Thank you very much. Sure.
Thank you very much. Before Charlie asks your question, Lupe, before you go, if you could comment, Lupe Mejia is our director of our low vision services. Tell us, in my mind, low vision services are for the large, enormous population of patients with AMD that we have, that lost central vision. In terms of children, how does that fit into the Low Vision Rehabilitation Center? And what interaction is there with VIPS or not?
Yeah, we've worked with VIPS at least as kind of establishing an understanding and making sure that children are getting into the system. For the younger ages, the preschool population that VIPS serves, they really are the best resource as far as advocating for patients, teaching parents to advocate for their children, and making sure that they've got the necessary services, particularly as it relates to their education. As children get older and go through the school system, our experience has been that we've got wonderful resources as far as their teachers for the visually impaired, but their teachers don't always understand the visual impairment. And so our role in the Vision Rehabilitation Program is to help educate their parents, educate their teachers, to help them understand what their visual impairment is, provide them with the tools and aids, which for children is usually kind of secondary. Children with visual impairments do very well. They adapt very quickly. They don't readily use magnifiers and telescopes. They tend to adapt close working distances and things very readily. But other things like lighting, we do use binoculars to help them with their orientation and mobility, the development of their perception, their peripheral awareness of their situation. So our role becomes more in helping everyone who's involved, their teachers, healthcare providers, and their parents to understand the visual impairment, and what resources might be available. So for example, the big mistake that we make in schools all the time is we enlarge everything. Kid has a visual impairment, we say just make it bigger, and that's not usually the best course for these children. So our approach is very, very different in children than it would be for our 80-year-old macular degeneration patients. It's a lot more education about the visual impairment and what the child is capable of.
Great, thank you. Charlie, question?
Yeah, so mom comes in with a 6-month-old infant, and the infant has nystagmus. It's a sensory nystagmus, and you look in and gee, you think the optic nerves maybe are a little bit pale. And mom says, can my baby see? What will my baby see at age 6?
Right,
Can my child go to regular school? How do you answer that
Yeah.
question, and how do you approach that?
Right.
Do you just say, well, I just have to wait and see, or what?
It comes down to a wait and see, but that's not satisfactory to parents.
Sure, yeah.
So what we typically do is say, okay, well, I think that this is what's going on, and particularly since your baby was 14 weeks premature and he's had a VP shunt, you know, we think that this is probably what's going on. But let's do some additional testing. We're going to get a flash visual evoked potential, and we're going to check out the amplitude and the latency of the response to see sort of how much damage is there. It's not an exact science, but gives us an estimate of sort of what's going on. You know, is it 50% of normal? Is it 30% of normal? Generally, if it's 50% of normal or above,
This is the VEP.
the VEP.
Okay.
And then we have the conversation of what do you think they can see when they're 16 after the VEP. And if it's above 50%, I tell them, you know what, we definitely know there's damage, but we can't say anything about it because we don't know what got damaged. Is it the central
Yeah.
fibers? Is it the peripheral fibers? We don't know. If it's less than 50%, it doesn't really matter. You've hit so much that they're going to have visual disability.
So my child that is in the neonatal intensive care unit and has a ventricular hemorrhage and has multiple developmental delays, comes in with a normal eye exam, but nystagmus. What do we say to that parent?
So those are, as long as they're tracking and they seem to be seeing normally, then we might do something like a Cardiff visual acuity test. So so that is like it's like teller cards, only with trains and fish instead of lines, because they're really boring. And then you can sort of get an estimate of what can they see. And if they're in the normal range for age, then you're thinking this is probably more of the nystagmus I didn't talk about, because it's more like in the adult range where you have strokes and hemorrhages in the brainstem. It's probably that kind of nystagmus. Very commonly, though, it's going to be a fusion maldevelopment nystagmus, because a lot of those kids, even though each eye can see normally, they weren't necessarily seeing together, and so they have disrupted binocularity, and they've got manifest latent nystagmus. Almost always. Not always, but almost always.
So the basic answer is you can't tell, but mom and dad want to
You can, again, I'm a lumper, not a splitter, so you can't say, well, I think they're going to be 20/80 to 20/100, but I can say, I think your kid's going to grow up and be fine, you know, with maybe, you know, it might not be 20/20, but they're going to be okay.
regular school.
They're going to go to regular school versus we need to plug you into delta gamma. I can make that discrimination with pretty good conviction. I mean, I'm wrong sometimes, but that one I can feel pretty confident about. But within the group that's going to go to school, I never tell mom, oh, I think they're going to have normal vision. I say it's going to be abnormal, but you know, it could be in any of a wide range. But they're going to get through the school system. They're going to be okay.
Well, I have a question. At the start of the lecture, we said that seeing the direction of the nystagmus is actually too subjective to rely on. It differs between different people. So, and then we said that a very important point to distinguish a congenital motor nystagmus from latent nystagmus is to see if the direction reverses. So how is that working clinically?
Right,
Do you
yeah.
really depend on that?
So let me tell you about the one I missed, and then that'll answer the question, right, because I missed it. So I had a girl that I thought she was a Down syndrome kid with a little bit of intermittent esotropia, and had what I thought was a periodic alternating nystagmus. Do you know what that is? So it goes to one side, and then it drifts back and goes to the other side, and then it drifts back and goes to the other side. Periodic alternating, okay? And that's what I thought she had, which was concerning to me, because that in a kid, you're going to want to scan. And she's got Down syndrome, so I'm going, okay, is it going to be like spasmus nutans? Do I not need to scan? Do I need to scan? And I thought, you know, this is one where I think I'd just like to get a second opinion. So I had her go for video recording, just like the one, actually all the video recordings you saw here, half of them were from Agnes's book, but she got those from our clinic. She was a fellow with us, and those were all Larry Tyson's patients that Dave Garibaldi filmed. And I sent them to Dave, and I said, you know, please record it, and, you know, get a long piece of tape so that I can sit down and really look at it. Because when you're trying to get it on the fly in the clinic, it's next to impossible. The video, you can watch it and watch it again and watch it again and watch it again. It's a lot more helpful. And when he did it, it became very clear that it was a manifest latent nystagmus. It wasn't periodic alternating. What was happening was she was esotropic and she was cross-fixating. So when she'd look with this eye, she was getting the drift towards the nose with the left eye, and when she'd fixate with this eye, because I was, you know, kind of watching her, and we'd get her to look at an object to try to have her track, and she was just alternately fixating, and whenever she was whichever eye was the non-fixating eye would have the nystagmus towards the nose, right? because that's how the
Yeah.
manifest latent works. So I just totally missed it and was able to figure it out by looking at the videotape, but I couldn't do it in the clinic.
This is a great tip. So you guys get at your damn cell phones and videotape the kid, and then you can sit down and look at it and figure out what's going on, because when you look at the child, you can't tell.
That's right. It's the same idea as doing those disc photos. You know?
Because I could never tell when I look at the patient in the office what the hell's going on.
I have a general question. It's a
Sure.
surgical question. We have a lot of pediatric guys here and yourself. If I'm, let's say, in the middle of Africa and I have a girl, teenager, 13, 14 years old, comes in with a large angle ET, and I have to fix that. I'm a cornea person. So, you know, when I have to fix that because that's the only way she's going to get married later on. Can I do it without general anesthesia?
Yes. So, well, particularly if, yes, you can. Now, it's easier, and she probably will be, if she's got a large congenital ET, she's 13, it's never been fixed, she's going to have one very amblyopic eye, typically. I mean, on rare occasions, they are alternate fixators indefinitely, but not commonly. So more likely than not, she's going to have one good eye and one bad eye, and then you just do an R&R on the bad eye with a retrobulbar block.
So it won't, you know, her heart rate won't get all messed up. And
Well, I mean, it depends on the 13-year-old.
To answer your question, when I was doing my residency in India, we used to do under retrobulbar.
Okay.
All the teenagers, we used to never use general anesthesia because it was so hard to, first of all, get it, you know, organized. So we used to do all our cases.
So a little story. I was in Pakistan about 4 years ago doing the same thing with general anesthesia. The anesthesiologist intubated the patient and then left and asked for 5,000 more rupees to come back in the room.
Now, see, they got it figured out.
They do.
That's why I'm asking.
Whoa.
What he did tell you was 5,000 rupees is $1.45.
Right.
Susan, thank you very much.
You're welcome.
Yeah, thank you.
We're going to take a 5-minute break, and then we'll start the session that we're going to start.
How are you? Good to see you.